This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is May 2026. Ryan, how you doing?
Good. Just got off a plane coming back from the
I
beautiful
know
United States.
You were traveling. Were you in Colorado? Is that where you were?
Yep, Colorado for an informatics conference, which
that sounds exciting.
Well, there was a lot of talk about ambient scribe technology, which by serendipitous association, we have two articles from this coming issue, two brief research reports regarding ambient AI-powered scribes in the emergency department. The first is by Jacob Rory at Mayo Clinic, titled Ambient Artificial Intelligence versus Human Scribes in the Emergency Department. And the second by Carl Priskatis at Stanford, titled Ambient Artificial Intelligence Scribe Adoption and Documentation Time in the Emergency Department. As you can probably gather, these are both evaluations of ambient scribe technology, the first making a direct comparison between AI-powered scribes and human scribes, and the second between AI-powered scribes and just manual, regular documentation. As far as the comparison to human scribes, this was a just how much AI slop is in this note, after all. What the authors did is they went back and looked at the documentation in the chart for patients seen by 5, quote-unquote, early adopter physicians, 284 notes produced by human scribes and 426 produced with AI scribes. And then they took a sample of 100 of them and used the Physician Documentation Quality Instrument, PDQI-9, to score them. And then they also overall looked at RVUs per patient, time and chart metrics, and other features of documentation. There's a lot of detailed data presented to comb through, but the basic gist is human scribe charts are better by about 2 points on the PDQ-9. But whether the difference between 38 and 40 on a scale that goes to 45 represents a clinically meaningful difference is a matter for debate. However, it's reasonable to suspect that the minor difference was enough to make a difference to the few physicians using the product, as the EHI logs clearly demonstrate a couple extra minutes on average per note versus the human scribes. There wasn't much difference in actual number of characters added or percentage of the note revised by the physicians, but the difference in time invested was consistent. Finally, in this tiny sample, they observed RVUs per patient were lower, but only for pediatric patient encounters. Then the Stanford group looked at usage patterns for clinicians in an environment where the scribe use was optional, but all physicians had access. This analysis looked at 8,700 encounters, 900 of which were documented with an ambient AI scribe. Nearly 70% of physicians never used the scribes, whereas a couple used them for nearly 80% of their encounters, as shown in what could be one of the most confusing figures I've ever seen before in Annals. But I digress. But part of this story is about adoption, looking at the zones in which initial adopters used the scribes, the distribution of which was mostly ambulatory triage and telemedicine zones for the ED. Then, from what the authors could glean from the EHR event logs, clinicians saved about a minute with the scribes, and notes were about 1,000 characters shorter on average. This is all sort of wrapped up with an editorial by David Schreiger and Stephen Schenkel, who wax poetic about the potential for ambient technology to save emergency medicine. They envision this future where omnipresent listening, anticipation, and full integration into the electronic health record might not just concisely document the salient data and insights, but facilitate the management plan, intelligently surface data, and nudge clinicians down the most fruitful paths, a reinvention of medicine. Well, I can certainly hope that is someday the case. For now, you're mostly stuck with AI slop notes and the first trepid steps of augmentation.
Yeah, I think I'm very bullish about AI writing my notes for me. So I'm fairly.
You would be the only one.
Despite this is very unimpressive results, right? I as you said, I don't think really those 2 points in whatever that note quality metric has a real meaningful difference. But even if you look at the time saved in the using the AI scribe compared to not using it at all, a 1 minute difference is fairly meaningless in the big picture. Though, over a lifetime of notes, it starts to add up.
Yeah, for sure. I mean, that's like a day's worth of time saved at the end of the year.
Yeah.
Even if it is just a minute per note. But I think the key is there's a whole bunch of other literature that's not these two little brief reports that just talks about measures of burnout and satisfaction. There's just such a cognitive load of having to do the documentation. It's just a non-fun task that you have to do at work. And this eliminates the worst of that, apparently.
Yeah. That's what I found. I use AI scribe for almost all my notes at this point, and my happiness at work has gone on exponentially. But the other part is we're just at the start, right? AI is just getting better and better, scarily so, to the point where, I imagine at some point we might never reach what Dave Schreiger is describing, but at some point we'll be able to offload much of these arduous tasks.
Yes. The AI that you use today is the worst AI you'll ever use in the rest of your life.
Yeah. I mean, there's a brief window when we can use it successfully and it will take over the world. But in that period, I tend to enjoy it a significant amount. All right, let's move on. Our next article is Sentinel Injuries in the Emergency Department and Subsequent Serious Injuries in Children. And the lead author is Stephanie Matrino out of Massachusetts General Hospital and Boston Children's Hospital at Harvard Medical School. So, I mean, I think we're all fairly familiar with sentinel injuries, these kind of minor bruises, fractures, and soft tissue injuries in young children who theoretically shouldn't be able to get those injuries themselves. And they've long been recognized as potential early warning signs for physical abuse. But the literature supporting how often these children actually go on to suffer serious abuse and actually go on to have a confirmed abusive case is not that strong. And so what these authors decided to do was conduct a retrospective study. They used a healthcare cost and utilization project, state ED and inpatient database from 5 states, Georgia, Iowa, Maryland, New York, and Wisconsin. And they looked at a time period of 2014 to 2019. They enrolled children 0 to 24 months of age who presented to ED with sentinel diagnosis using the Lindbergh criteria. So these are bruising and oropharynx injuries under 6 months, extremity fractures and intracranial hemorrhage under 12 months, and rib fractures or subconjunctival hemorrhage, genital and thorax and abdominal injuries under 24. And so what they did, they looked at a lot of patients, a total of over 23,000 children. The median age was 5 months. 53% were boys. The most common injuries were bruising at 39% and extremity fractures at about 20%. 80% were discharged home from the index visit. Skeletal surveys were performed in only about 6%. So over the next 12 months, very few children ended up with a serious injury at 0.7%. And mortality was 0.05% over the next 12 months. About 4.8% of the children were diagnosed with child abuse at their index visit. 8.3% of those went on to have subsequent serious abusive injury within the next year. So that was the high risk group. Overall, this is a fairly low risk group. There was an accompanying editorial by Casimir et al. That points out that while the risks appear very low, it's important not to completely discount sentinel injuries and more studies are warranted. And while this is true, the risk does appear to be very, very low. And maybe we should start rethinking what we consider a sentinel injury and whether they actually do identify the patients at risk for abuse. I think what really matters is we need to do more research on it.
Yeah, I mean, I think that there's just so many injuries, and so few of them actually portend serious either abuse or a potential opportunity for a missed opportunity for diagnosing abuse. And these authors, I think they pretty much sum it up correctly at the end, that they need better tools for risk stratifying these patients who have these sort of supposed sentinel sorts of injuries, because this is not a high enough yield sort of investigation to rely upon to predict future children at risk. All right, we will move on to the next article, which is also pediatrics, and this one is called Feasibility of Pediatric Diagnostic Quality Measurement in All United States Hospitals. Our lead author is Kenneth Mickelson, and they're at Lurie Children's Hospital in Chicago. And this is a bit of a meta-quality research focused primarily on the pediatric population presented to emergency departments. And we'd all like to be able to identify recurrent or systemic missed opportunities for diagnosis in the pediatric population, but is it actually reliable to do this from a high level? And the answer is basically no. These authors took a sample of 20% of US EDs within the nationwide emergency department sample, and then just simply counted the number of child visits to each emergency department, with one of 24 serious pediatric emergency diagnoses. Some of these are difficult diagnoses to make, depending on context, testicular torsion and appendicitis, for example. And these authors wanted to know if the frequency of these diagnoses at each hospital, in order to determine whether it was even possible, statistically speaking, to reliably measure a deviation from a national baseline of quality. So out of the 4,500 EDs in their sample, only 600, or 13%, met a threshold for statistically reliable measurability of even one of those 24 serious diagnoses. Then, however, there were only frequent enough diagnoses for a couple conditions. 11% of EDs had sufficient diagnoses of appendicitis, but less than 1% for testicular torsion, complicated pneumonia, and intussusception, and none of the other 20 were frequent enough to even reliably measure quote-unquote quality. So in any event, it doesn't appear measuring deviance from a misdiagnosis baseline is the best way to go about determining the quality of care in a particular hospital. The numbers are just too small to do in pediatrics. Other strategies to identify missed opportunities for diagnosis will be needed.
Yeah, they sort of hint at, like we can combine all these small hospitals to get some idea, but then you're sort of missing the point, right?
Because
You
every
want to,
hospital is different,
yeah,
so you can't
right.
pool
And so,
different systems, different pools of doctors, different training,
right.
different culture, everything,
And then you want to look at the quality of one
resources.
hospital or another. It's hard to do if you're pooling them.
Yeah, I mean, you could probably pool a whole class of hospitals with a certain level of capability. They don't have 24-hour ultrasound, or they don't have in-network children's hospital to transfer to, or something like that. And pool a whole bunch of small hospitals together with certain characteristics, and say, well, these types of hospitals, they are missed. They have these missed opportunities for diagnosis in children. But then again, are those modifiable? You can't take critical access hospitals and turn them into pediatric tertiary centers. No, but anyways, yeah, from their statisticals, this sort of meta research sort of thing, yeah, that this is not a worthy strategy.
All right. Our next article is Risk Factors for Pediatric Deep Neck Infections, revisits after emergency department discharge for pharyngitis or local neck symptoms. And the lead author is Kayleen Jafari from Seattle Children's Hospital and the University of Washington. These are the often feared deep neck space infections, retropharyngeal abscesses or parapharyngeal abscesses. They're super rare, but we're often told about them and thought to think about them in most patients presenting with pharyngitis or neck pain otherwise for no reason. But the data on how often they happen and how often they have previous visits that are missed is a little unclear. So these authors did a cross-sectional study using state ED and inpatient databases from 6 states: Florida, Maryland, New York, Wisconsin, Iowa, and California. And they looked at 2018 through 2019. They did what's called a SPADE methodology, or symptom disease pair analysis of diagnostic error, which essentially has a look back phase and then a look forward phase. In the look back phase, they identified a number of pediatric deep neck space infections. In this case, 799 infections using ICD-10 codes. And then they basically linked those admissions to any treat and release ED visits in the prior 10 days prior to presenting with this deep neck infection. And then during that, they kind of looked at what these visits were most commonly presented for to the ED when they presented in the previous time at least. Using that, they then conducted a look forward phase where they looked at these highest diagnosis for ED visit prior to being discharged, prior to coming back with a deep neck infection. In this case, it was pharyngitis and tonsillitis. And they looked at a large number of cases presenting with pharyngitis and tonsillitis and see how many of those then subsequently present later on with one of these deep neck infections. In the look back analysis, about 18.3% of the kids with a deep neck infection had an ED treat and release visit in the prior 10 days. Most of what was represented in these was pharyngitis, tonsillitis, or neck pain. They then conducted this look forward, and for pharyngitis, tonsillitis, it was over 400,000 patients, and for neck pain or torticollis, it was over 50,000 patients. When you were looking at prospectively from a forward perspective, deep neck infections or recurrence after an ED discharge was incredibly low. 0.014% of pharyngitis visits and 0.07% of local neck symptoms ended up coming back with a deep neck infection. They tried to figure out some predictors that would help you predict which patients were at higher risk. So younger age was one of them, and then concomitant fever with neck pain was another one that seemed to increase the odds a certain degree. There were other things like neck imaging, but these are likely to reflect just a general suspicion of the clinicians at that time. There was something that obviously made them more concerned than normal. Overall, while there are things that seem to increase the risk is still incredibly, incredibly low. It's hard to know exactly what to do with this data. Like even if you had patients with neck pain, the risk is still infinitely small. What I would say is, I think just the general thinking probably still stands. When you have patients that have neck pain and a fever that you can't quite explain, you should probably be somewhat more concerned for these deep neck infections. Outside of that, it's really hard to know exactly what to do with this.
Somewhat more concerned is basically slightly more than zero because your base pretest likelihood for this disease is virtually zero. So somewhat more concerned is still somewhat more is basically zero as well. Yeah, if you're the first visit for these sorts of things, I mean, I think that unless it's really just screaming at you, this person has external signs of soft tissue swelling and they won't move their neck and they have a fever. Okay, well that's great. But if it's just a non-specific symptom in a child that can't tell you and describe a whole lot of things, the first visit, you don't even put it out of your mind. The second visit, put it in your mind again. That's basically like emergency medicine for you. It's like the best test sometimes is time. There's not a lot of these things. These people got imaging sometimes, and it still didn't identify their deep neck abscess because it was just not. It had not manifested completely. So it's just as per usual. The best test is time, good safety netting, return precautions. They come back, you make the better diagnosis. Easy. Emergency medicine. So easy. All right. We'll move on to a totally different topic here. And the next article we'll talk about is GFAP and UCHL1 for acute traumatic intracranial lesions, the Pioneer Diagnostic Accuracy Study. Our lead author here is Nathan B. Roberts, and they're at the University of Michigan. And if you remember a few months ago, we discussed a meta-analysis that looked at these two biomarkers regarding their sensitivity and specificity. The meta-analysis, based on the specific statistical machinery involved, took a series of studies with less than 100% sensitivity and spit out 100% sensitivity. And you're welcome to go back and listen to that if you like. But this is just one example of that. Well, not 100% sensitivity for these biomarkers. These authors took incidental blood samples of 1,800 patients undergoing a head CT following blunt trauma, froze them, and sent them to the central laboratory for analysis. It then used the findings of the head CTs to correlate with the biomarkers to determine which of them the performance characteristics of these assays. The other somewhat important aspect of this study is that it used these biomarkers on the Abbott iStat platform rather than something down in the laboratory, as that is likely more relevant to how this is going to be used in practice. In any event, of the 1,800 patients, 1,300 of them were quote unquote positive on this GFAP UCHL1 assay. Of these assay positives, these 1,300 assay positives, 47 had intracranial lesions. Then there were 500 odd assay negatives, and 2 showed positive findings on CT. So a sensitivity of 96% with really wide confidence intervals, and a specificity of 30% with fairly precise confidence intervals. The 2 cases missed by the assay did not require neurosurgical intervention, but they were observed and did undergo repeat scanning, as both were at higher risk for complications due to either antiplatelet use or a cirrhotic coagulopathy. But there is basically a lot more to unpack within the article, comparing it to other studies, particularly down to the granular patient's characteristics, demographics, time to blood sampling, and laboratory processing procedures. But the general gist of it is that these data are fairly consistent with the bulk of all the other literature out there showing these assays return false positives the vast majority of the time. And then you have to worry about whether the assay that misses in the neighborhood of 1 out of every 25 intracranial bleeds is clinically acceptable in the United States. And then you put this in the context of the potential for CT reduction, where overuse is rampant. There's an editorial by Papa that basically argues that we are using so much CT that it's probably okay to have these what she hopes are non-clinically important misses, and that these assays could potentially reduce CT in the overall. Obviously, overseas or where practice patterns differ, the lack of specificity is the most troubling aspect, and is probably going to increase utilization without improving clinical sensitivity or outcomes.
I don't think in the history of medicine has a non-specific blood test ever reduced the testing of another test. It just doesn't work like that, right? Like, the easier it is for us to order something, the more we order it, and thus the more CTs we're going to do. Yeah,
those stuff start doing it at triage. It's an iStat.
Exactly what's going to happen, right?
Yeah. And anybody with a head injury is going to get one of these run up at triage because they've got a 5-hour wait. You don't want there's going to be a time to diagnosis metric for intracranial hemorrhage or who knows what.
D-dimer of the head, right here. And if you just like compare this to like the Canadian head CT rule, the Canadian head CT rule works much better than this. Why aren't we using something like that, right? Like, it's just
there's so many exclusions. You have these people on antiplatelets. You have them on blah blah. There's
Right, but those might be the same patients that this doesn't work for, right? Like,
and if you go into these assays, there's a whole bunch of different confounders. There, as you get older, the more likelihood it's going to be positive. Yeah. There's concerns about being intoxicated and other things that interfere with the assay. So, yeah,
it's the D-dimer of the head.
Amazing. What a time to be alive.
As usual, I'm very skeptical this will do anything good because nothing like this ever has before. All right. Our next paper, early intensive blood pressure reduction after intracerebral hemorrhage is associated with worse functional outcomes, the risk of overshooting blood pressure goals. And the lead author is Aria Shi from the Brigham and Women's Hospital and Massachusetts General Hospital at Harvard Medical School. So I really like this paper. This is based off a number of randomized clinical trials that were published a few years ago, the ATTACH-2 and the INTERACT-2 trial, which looked at patients presenting with intracranial hemorrhage and seeing if aggressive blood pressure control early in their care, in the theory that the faster and the tighter you control blood pressure, the smaller the hemorrhage in the brain is, would improve outcomes. These are somewhat controversial papers. Both of them, their primary outcome was negative, but they found some subgroups where there might be a possible event of it. Most specifically, the patients that got the fastest blood pressure control. So patients that were aggressively controlled quicker seemed to have better outcomes. And so this has been kind of broadly recommended. The AHA guidelines recommend aggressive, drastic blood pressure reduction between 130 and 150 in these patients. And it's kind of broadly adopted across care. But the concern here is, how does this look in the real world? And what are actually the clinical consequences, especially given the fact that primary outcomes in these trials were negative? So what these authors did was they essentially conducted a retrospective study out of two large academic comprehensive stroke centers, Mass General and Brigham Women's. And at these centers, they use the AHA Get with the Guidelines stroke registry. They have a pretty extensive registry that these patients get enrolled to when they present to these hospital. They have all their care data warehoused and gathered along with outcomes and functional data at 3 and 6 months. And so they essentially looked at this and they did a pretty extensive analysis. Basically looked at patients presenting to the emergency department, and specifically the ones who had a blood pressure greater than 150. And then they looked how long it took clinicians to get that blood pressure under the control. And they defined control as less than 1. They also looked at how often the blood pressure was overshot, which they defined as a systolic blood pressure less than 120. They basically broke this down into groups that less than 2 hours, less than 6 hours, so on. And then they just looked at outcomes, and they defined outcomes by the modified Rankin scale, which I think we're all fairly familiar with now. And they dichotomized this. So 0 to 3 was a good outcome, and 4 to 6 was a poor outcome. Overall, they looked at 420 patients. There was over 1,000 patients in the registry, but unfortunately, many of them didn't have all the results they needed to conduct this analysis. So in the end, they came down to a little over 400 patients. The mean blood pressure on arrival was 180 systolic. 70% of these patients had a systolic blood pressure greater than 150 on arrival. Of those, 63% received antihypertensive medications within the first hour, and 71% achieved their goal within 2 hours. So what they found was achieving blood pressure goals within 2 hours was associated with worse functional outcome and adjusted odd ratios of 2.3. So not better, but these patients seem to do worse. Overshooting within 6 hours from presentation. So that's in the patients who got a blood pressure below a systolic blood pressure less than 120 happened in about 50% of the treated patients. And this was also independently associated with worse outcomes. They also found that patients who were likely to hit their blood pressure goal within 2 hours were also more likely to overshoot. Now, one of the interesting things is when they actually controlled for patients who overshot their blood pressure, it seemed rapid control of the blood pressure was no longer a risk factor, an independent risk factor of poor outcome. And so what this essentially means, it's likely the patient overshoot or dropping your blood pressure too quickly, too much, too fast that are going to lead to worse outcomes. They found that neither bolus nor infusion predominantly caused overshooting or not. But essentially what it looks like here is there is a risk of poorer outcomes when you drop patients' blood pressure too aggressively, too quickly, specifically in this idea of dropping their blood pressure below a certain threshold. Now, 120 is sort of made up, and it's kind of silly to think that every patient's different. The thought is here there's some ischemic penumbrae that exist inside the ICH, and decreasing their blood pressure too much will cause more ischemia, leading to worse outcomes. This is not insane. The actual, if you look at, the actual randomized controlled trials, both Interact and Attached, they did show that patients had worse outcomes in certain perfusion metrics, most notably as a lot of these patients had worse kidney function when you drop their blood pressure aggressively and fast in the test group versus the control group.
Yeah, I mean, I think I like this paper as well because it's what's the real world look like? We have this trial performed with, research assistants, constantly titrating the blood pressure and making sure that they're reaching the specific goals in the protocol so that they don't have any protocol violations. And yes, you've struck that narrow sweet spot of potentially perfusing what you need to perfuse without damaging what would be damaged without it. But in the real world, we don't have that level of monitoring, and the overshooting is very concerning, to put it mildly. And I think that's as pervasive as generally speaking, it's going to be this. I think this hospital's experience is at least as representative, if not, and community hospitals might even be worse.
Yeah, I would say this is the best of the real world, right? Like
Best of the real world.
This is like Get with the Guidelines hospital. These are the stroke centers. They have the most resources. When you do this in a busy community ED, where you've got someone on the cardipine and the nurse watching them has 7 other patients, the risk of dropping your blood pressure too quickly, too much is obviously exponentially higher.
Yeah, I mean, not to date ourselves too much, but this reminds me a lot of of NINs.
Yeah.
And then you had the articles they published afterwards, like the thrombolysis in real world use, like the Cleveland experience,
Yeah.
where people did awful with thrombolysis compared to the trials. Here it is. It just shows the difficulty. You got a trial with internal validity, but no external validity whatsoever.
Yeah, I mean, I would argue you might not even have real internal validity. Like,
we're presupposing that because we don't want to get into a bigger debate in this article.
Yeah, I mean, like that's the scariest part about this. The initial trials were both negative, and it was only subgroups that showed this positive signal.
Excellent.
I think that wraps us up for another month.
It does.
All right.
It's the end of May.
Yes.
And the next month will be June.
It will be June, and we'll be back. As always, with any questions, comments, or concerns, we can be reached at annalsaudio@asap.org. Otherwise, until next time, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.